Hello, my name is Jorge Cortes from the Georgia Cancer Center at Augusta University, and I'm glad to talk to you about some of the new developments and some of the evolving things in the management of patients with chronic myeloid leukemia in this 2024. And I will start with our frontline therapy and how we go about deciding how we treat patients, because now we have four tyrosine kinase inhibitors that can be used as initial therapy for CML. And why would we select one or the other? Of course, the first decision we need to make is, am I going to use imatinib or am I going to use a second generation TKI? And then if I'm going to use a second generation TKI, which one am I going to use? There's three of them available. So why would I choose imatinib? Well, we have the longest follow-up. Of course, we have very long follow-up with all of them, but certainly the longest is imatinib. Very importantly, we have the lowest risk of arterial occlusive events and cardiovascular toxicity with imatinib. And ultimately, the event-free survival and overall survival is the same with imatinib as with second-generation TKIs. And because it's now generic, the cost is the lowest with imatinib. Why then would we choose a second-generation TKI? Well, we know from randomized studies that they provide the fastest responses, the deepest responses, actually the highest rate of response overall. And most importantly, it gives us the best possibility of having patients become eligible for a treatment discontinuation, which has become an important goal of therapy. How do we select these agents? Well, one of the approaches that has been proposed by some of the guidelines is by the SOCAL classification, or it could be one of the other risk stratifications and used, for example, for the high risk patients, the second generation TKIs. And although there is some reason why that has been proposed, I'm showing you here how, with all these randomized studies, they all have suggested that even patients in the low risk category benefit from second generation TKI. Certainly, there is more improvement to be made in the high risk category patients, but even the low risk category patients, if I'm a low risk so called patient, I would want to have that potential benefit of a second generation TKI. So I think we're focusing more on other criteria. For example, what are the goals of therapy for a patient? What are the comorbidities? And based on that, make our selection of the tyrosine kinase inhibitors. Another important thing to recognize is the actual expectations of treatment with the tyrosine kinase inhibitors, both with imatinib and second generation TKI. And for that, I refer to the NSTND study because we have the longest follow-up, 10 years of follow-up. So it is important to recognize that not everybody is going to get a major molecular response. By 10 years, you get about 80% of patients maximum with nilotinib and less with imatinib that are going to reach a major molecular response. And as you can see at the top left here, we've reached the ceiling. That's about it. MR 4.5, even a lower probability, probably only about 60% of patients are going to get to an MR 4.5. And if we focus on sustained MR 4.5, which is what we need to consider treatment discontinuation, 50% at best are going to get to that. So really, not everybody's going to get there. And that's important because there is this attempt at getting everybody to an MR 4.5, and sometimes we see all these constant changes to try to get there when we realize that not everybody's going to get there, even when they're otherwise doing very well. And when I mentioned that we change therapies, it is also important to remember that these second generation TKIs are fairly equivalent in terms of efficacy. This is a recently published randomized study from Japan of initial therapy with dasatinib versus nilotinib. And you can see that the results are pretty much identical with the two strategies. So really, there is very little expectation that you would get much more by switching a patient from one drug to another drug. And although the dasatinib is not here, I would imagine that you would probably expect very similar results with bosutinib as you do with nilotinib and dasatinib. Another important consideration that is evolving is what is the right dose. And that particularly is relevant now, it recently has become a question with dasatinib. And one important study to discuss what is the right dose is this randomized study from France. A reminder, the standard dose is 100 milligrams daily. So in this study, everybody starts with 100 milligrams daily. Patients that have concentrations after 7 to 10 days of therapy of less than 3 nanomolar, they continue their dose. The patients that have more than 3 nanomolar in their plasma, they're randomized to either continue with the standard dose or adjust the doses according to the plasma levels. And you see on the right hand side that a lot of these patients actually end up taking, pretty much everybody's taking lower doses in the long term. What's most important is that when you look at the rates of pleural effusions, the patients that had lower plasma levels or the patients who adjusted the doses have a much lower probability of having a pleural effusion in the long term than those patients that continued with the standard dose even when they had higher plasma levels. Now we don't measure plasma levels in the clinic, so that's a limitation for these, but it shows that we reduce significantly the risk of the pleural effusions by maintaining lower plasma concentrations, whereas on the right you can see the probability of response is exactly the same no matter what. There's even an even more aggressive approach, and this one is a study for older patients, older than 70. And in this study, everybody starts with 20 milligrams of dasatinib. And what you can see is that the molecular response rate, the major molecular response rate at 12 months, is 60%, an excellent response rate, even when you start with the lower concentrations. Now, this study offers the option of increasing the dose slowly if the patients are not responding, but that means that only a fraction of their patients are going to need really higher doses. And there's this study from my former institution where we treated patients with a starting dose of 50 milligrams daily instead of 100 milligrams daily. And as you can see, when you compare the two studies that we did at the same institution, 100 versus 50 milligrams, these are sequential studies. It's not a randomized study, but you can see that the expectation in terms of response is very, very similar whether you use 100 or 50 milligrams. Now, none of these studies has changed the standard of care because the indication, the label still says 100 milligrams, but it clearly shows that in the frontline setting, you can do with lower doses of dasatinib. Another important piece of information in terms of the frontline therapy is a study that was just very recently presented at ASCO and published in the New England Journal of Medicine, which is a randomized study of asciminib as initial therapy for chronic phase CML. We know that asciminib has been very effective and it's approved for patients who have received 2 or more TKIs or who have the T315I. But in this study, it's initial therapy for patients in chronic phase. And patients were randomized to receive asciminib or any of the available tyrosine kinase inhibitors for frontline therapy. One important element of this study is that before randomization, the physician had to decide if my patient is randomized to the control arm, am I going to give them imatinib or am I going to give them a second generation TKI? So that's what you see these strata there for the imatinib strata and the second generation TKI strata. And there were two primary endpoints, asciminib, major molecular response at 48 weeks, asciminib versus any TKI, or asciminib versus imatinib. So what did the data show? Well, first is that there's far fewer patients who discontinued asciminib compared to any of the TKIs. Whether you look at the overall population, the imatinib strata, the second generation TKI, grossly the rate of discontinuation with asciminib is about half than with the other TKIs. And that applies whether you look at discontinuation because of treatment failure or whether you look at discontinuation because of adverse events. In terms of efficacy, at the far left, you see here the rate of major molecular response. And first, I'm showing you against all of the TKIs. And you can see significantly better probability of response with asciminib, with a differential of almost 20%. But even for some of the secondary endpoints, efficacy endpoints, early molecular response, that is PCR of less than 10% at 3 months, or even the deeper molecular response, even though it's early, just 48 weeks, you already see a sizable difference in favor of asciminib. Now, if you look at the strata of imatinib, the other primary endpoint, the differences are even greater. Certainly, the primary endpoint, major molecular response at 48 weeks, the differential here is almost 30%. And again, also a big difference in favor of asciminib for early molecular response, MR4, MR4.5. Now, the comparison between asciminib and second generation TKIs is just descriptive. The study was not powered for this difference, for this comparison. But even then, you see that there is a benefit with asciminib compared to the second generation TKIs, again, in all of these parameters: major molecular response at 48 weeks, and early molecular response, MR4 and MR4.5. So if you look at all these data that I talked about now, and this is a complicated table, but it summarizes the results that we have from all of these randomized tables. In the middle, you see the pivotal studies for dasatinib, nilotinib, and bosutinib, with the data that we all know, superiority of second generation TKIs versus imatinib. On the left, you see the Japanese study of dasatinib versus nilotinib, and on the right, you see the asciminib versus newer generation TKIs. So all of this is suggestive that uh, certainly second generation TKIs are better than imatinib. Now, I have to emphasize, imatinib is a good drug and it's a good choice for many patients. But second generations have advantages. They all seem to be equivalent, and that's confirmed by this randomized trial of dasatinib versus nilotinib. And asciminib may be the next step up in our management of patients with tyrosine kinase inhibitors, particularly when we are interested in the deeper molecular responses in the long term. We have to see longer term follow up. Now let's move to the patients that have resistance or intolerance. We all know the ELN and the NCCN guidelines that tell us when a patient is having an optimal response, but importantly, when they have a true failure, or what the NCCN presents in red, or patients that have an intermediate response, a warning, a suboptimal response, or the yellow and orange classifications according to the NCCN. In the failure, it is clear we have to change therapy. Those warnings, those suboptimal responses, those are categories where you probably just need to have a closer monitoring of the patient, but a change is not necessarily indicated at that time. And this is important because in these recent analyses from the German studies have shown that patients that don't meet those criteria for optimal response, they may still have a very good survival, particularly when you talk about those criteria at the early time points. At 3 and 6 months, you see here in the left two panels how the survival is very similar to the patients that have an optimal response. So there's no really need to obsess too much about these responses. Certainly, you have to monitor your patients closely and pay attention to the doses and all of that. But it is still possible to have a very good outcome in those patients. And that's important because that 3 month early molecular response has become a controversial area where some suggest that you need to change therapy. But there was this recent randomized study of patients receiving imatinib who then switched therapy, were randomized to switch therapy to dasatinib or continue imatinib if they had more than 10% transcripts. And you can see that on the one hand, the probability of major molecular response at 1 year, which was the primary endpoint, was better with dasatinib. But number one, the difference is relatively small. You see those curves, they separate by only about 5 to 10% percentage points. But more important, there is absolutely no difference in progression free survival or in overall survival. So, really, the benefit of changing at this 3 month mark is really not demonstrated with this study. So I personally do not change in this context, but I do monitor and check again at the 6 month mark to make sure that the patient is advancing. And many patients do progress better; they do advance their response better by 6 months. When we need to change, if a patient is on imatinib, we know that we have second generation TKIs and they work well. But I want to emphasize that the response is not as well as we tend to think sometimes. You see, these pivotal studies show that only about 40% of patients that received dasatinib, nilotinib, or bosutinib after imatinib failure have a complete cytogenetic response, not molecular response, complete cytogenetic response. Now, what I showed you there was 2 years, and we have now 10-year follow-up for bosutinib. And as you can see here, it has improved only very slightly. The rate of complete cytogenetic response by 10 years is only about 50%. So again, yes, we have good treatment, but there's really a lot of room for improvement. Now, the improvement can come from different areas. One of them is to learn how to use our drugs better. And this study using bosutinib again and focusing on older patients, age 60 or older, they started with lower doses of bosutinib because, as you know, bosutinib initially can be tricky because of the diarrhea. So they started with lower doses, 200 milligrams. After 2 weeks, they go to 300 milligrams. And then, depending on the response, they either continue with 300 milligrams if the patient is responding well, or increase to 400 milligrams. And what you see here is a very good response rate. Look at the probability of a complete cytogenetic response, cumulatively 84%. The major molecular response, 65%. So as good or even better than what I showed you earlier. So that shows that managing your patients well can lead to optimization of the probability of response. We also know that the patients, a way to select the treatment option for the patient is by knowing what mutation the patient may have. And based on that, both the ELN and the NCCN recommend what drug you can use or not use. Now, keep in mind that there's only a few mutations that are informative in this regard, that where there is benefit with one drug versus another. So that is one important consideration regarding the mutations. But the other thing is that only about 25% of patients have a mutation detectable when they have resistance, have a mutation detectable by regular sequencing, which is what most of us do in the clinic. Even if you do next generation sequencing, it's less than half of patients who actually have a detectable mutation. And of course, that means that half of the mutations you detect are so low levels that you could even question how clinically meaningful they are. But even more, um, the patients that have a mutation, you really probably can explain better why they are not responding to therapy. The problem is the patients that do not have a mutation. And giving you the example of ponatinib, a very effective drug, you can see that the responses are the worst among patients that do not have a mutation. So to me, the patient that's most problematic is the patient that does not have a mutation, not the patient that has a mutation. Even the patients that have a mutation with no difference between the different drugs. Well, in that regard, perhaps an explanation is some information that we've started gathering recently that shows that somewhere between 20 to 30% of patients at the time of diagnosis have mutations in other cancer related genes, ASXL1, RUNX1, DNMT3, etc., or have other rearrangements with BCR or ABL, but that are not BCR ABL. And very importantly, those patients that have those rearrangements, again, at the time of diagnosis, they have a much worse probability of achieving a good response to therapy and a much greater probability of progressing even to the accelerated and blast phase. So it is very important that this may be a mechanism of resistance for those patients where we don't have an able mutation. Uh, the other thing that's important is that in this retrospective analysis from Australia, they looked at all the patients where they identified the mutations. They saw what they had used as treatment initially, and as you can see, second generation TKIs really do not do any better for patients that have an ASAXL1 mutation compared to imatinib. Now, this is a retrospective analysis, but in a way, it makes sense because these drugs are not ASXL inhibitors, so you wouldn't expect a much better outcome. So this is a population where we still have a big question: what should we be doing with these patients? Then, third line therapy, when a patient has received two prior TKIs, well, number one, if they already have resistance to one second generation TKI, going to another second generation TKI offers very low probability of response. This is a list of case reports and case series. And as you can see, the probability of complete cytogenetic response is only 20 to 30%. Ponatinib is very effective in this setting. You can get major cytogenetic responses in up to 60% of patients, even higher if they have a T359 mutation. And these responses are very durable. The problem was the arteriocclusive events that we saw with ponatinib, and that led to this study that looked at what is the optimal way of using ponatinib. And it looked at two different things. One is what's the best starting dose, 45, which is the standard, 30 or 15 milligrams daily, and then lowering the dose to 15 milligrams once the patient responds. And what this shows is number one, 45 milligrams is clearly the better drug, the better dose for ponatinib in this context. But by reducing the dose, you significantly decrease the risk of arteriocclusive events to a much more manageable rate of somewhere between 10 to 12%. So this is now how we use ponatinib, and perhaps we should ask ourselves, is this the way we should be managing other drugs as well, although that has not been tested prospectively. Now, I talked about asciminib, and a reminder, this is a drug that works differently. It's not an ATP competitive inhibitor. It binds in this myristoyl pocket that is an autoinhibitory domain for the ABL. When ABL is bound to BCR, that is lost. And when you introduce asciminib, then it inhibits the kinase activity. It is not. It is affected by different mutations than the traditional tyrosine kinase inhibitors. You see on the right, the blue is what mutations affect nilotinib. On the pink, you see what mutations affect asciminib. These are mutations that happen in the myristoyl pocket, not on the ATP binding pocket. The results from an initial phase 2 study showed very active drug against patients that have multiple prior TKIs on the left, or even on patients that had a T359 mutation, and that was whether they had received ponatinib or not. And in the randomized study against bosutinib, we saw a very high difference in favor of asciminib compared to bosutinib that led to the approval of asciminib in this context. Now, that difference is seen no matter what kind of patient characteristics or disease characteristics the patient may have. It's seen across the board. And although that study did not include patients with T359 because bosutinib doesn't work in that context, there is a separate study in patients with T359 that demonstrates the benefit in these patients, with almost 50% of patients achieving a major molecular response. It is important to note that you need a higher dose for these patients, 200 milligrams twice daily compared to the 40 milligrams twice daily or 80 milligrams once daily for the patients that do not have a T359. So that is important to keep in mind. Now, I also want to remind you again that how you manage your patients is important. These are two separate studies that use bosutinib as third-line therapy. On the left, the ASSEMBLE study, and you see that the major molecular response at 1 year with bosutinib is only 13%. On the right, you see the BEYOND study. The major molecular response at 1 year is 70%. the discontinuation rate much higher in the assembled study for bosutinib. So these are just differences in the management of the patient. So it's not just what drug you use, it's how you manage your patient. Um, Finally, talking about asciminib, I mentioned earlier those mutations in ASXL. Well, unfortunately, they also affect asciminib. In this study of patients that have been heavily pretreated, the probability of failure to asciminib is much higher for patients that have any of these other mutations. In terms of adverse events, very briefly, we all know the differences in the toxicity profile between nilotinib, dasatinib, bosutinib, and them against imatinib. So I'm not going to go too deep into those differences. But I do want to show you the results in the asciminib versus other TKIs. Just to show you, as you can see here, for hematologic toxicity, the toxicity with asciminib is very, very similar to what you see with imatinib or with second generation TKIs. And the same can be said about non-hematologic toxicity. Very similar toxicity profile. All the adverse events are the same or lower rates with asciminib. It's a very well tolerated drug, which is important because those patients who cannot stop therapy, at least we are expecting a better quality of life in the long term. In terms of arterial-occlusive events, we know that that nilotinib and dasatinib double the risk of arterial-occlusive events compared to imatinib. Bosutinib has a rate that's a little bit higher than imatinib, but not quite as high as nilotinib or dasatinib. And with asciminib, you see on this randomized study versus bosutinib that the rate is a little bit higher than bosutinib. It's definitely not quite as high as nilotinib and certainly not as ponatinib, but we need to keep in mind that we always need to monitor those comorbidities and manage them prospectively. And in the frontline study, very, very few arterial occlusive events. Overall, only a couple of patients with asciminib, a couple of patients with second generation TKIs. Um, Finally, it's important to make sure that arterial occlusive events are really arterial occlusive events and not just chest discomfort and things like that. And in an adjudication study from ponatinib, we see that the true incidence of arterial occlusive events, even before the OPTIC study, was only 17% and not 25%. And just a reminder, there are a number of other TKIs under development. I'm not going to go into too much detail into them. This is just a listing. They're very promising drugs. They all have qualities that may be beneficial. Some of them are advancing into pivotal studies like olverembatinib. And we just need to keep our eyes on these drugs because they may become part of our armamentarium in the near future. So with that, I conclude. I stop here. I thank you for your attention.